everyone. Good afternoon. It's a pleasure to see all of you in person and not in a little box. I'm usually the radiologist in the dark room in the little box. So many of you are colleagues, collaborators, and friends, so it's really nice to have this opportunity, and I hope I make more colleagues, collaborators, and friends today, and introduce you to the rest of the radiology department. There's more than just me out there, I promise. Okay, so this is a very general title. They asked me for this title about I don't know how many months ago. So we'll get. It's very general, but it's mostly about MR. That's my expertise. I'm an MRI physicist, and I'm a body and breast imager clinically. So let's get into it. These are my disclosures. There's lots of benign diseases and lots of malignant ones. I'm not going to dwell in this audience about any of those, but we'll go right to the pictures. We do read your notes. So sometimes I'll qualify that. Sometimes. So we appreciate it when you put your notes in there. This was not written by any OB-GYNs, but a general order, part of a note where a patient had pelvic pain. She was in her 80s. She had pelvic pain for many years, and the ordering physician had decided that he suspected psychiatric diagnosis. And this was one of our faculty. So I want you to know that this era has not left us. This was just a few years ago when I read this note in the chart. And there are actually ways. This patient had never had any pelvic imaging to evaluate for pelvic pain. So I'm glad he made he put that in his assessment. And I want to talk a little bit about pelvic pain. It's a big problem. This is what this slide summarized. Pelvic pain is a big problem, but there are ways of evaluating it. And it's sort of one of the new areas that I'm branching into now, is trying to, and Irene took me for a very long walk, and we talked about endometriosis. I appreciated the encouraged exercise and science talk. So this is an area where I really think that radiology can collaborate with you guys in sort of exploring new avenues and solutions for evaluating pelvic pain, especially when we don't really know where it's coming from, and having different modalities of evaluating it. So when I started as faculty, I met with Dr. Agarwal. This was one of his patients. And if you guys can see this little tiny, tiny white spot here on the uterus, that was representative of this whole mess that he saw in the operating room, representing an endometriosis. So on MR, when we're like tiny implants, and then you guys like, oh my God, it was a hot mess and all these adhesions, and why didn't you see this? I was like, look, this is what I saw, okay? I'm doing my best. I'm doing the best I can. Your eyes are going to be better than anything I see. But I think that this is where we're making a lot of improvements. Some of the MR technology has really, really improved over the last couple years. We have a collaboration with GE where we're the site that's determining all of their MRI protocols that they're going to be using and distributing and trying to democratize imaging so that you can have experts determine the protocols and then them used worldwide wherever there's their type of scanner. So this is this is a T2 image. So whenever you hear a radiologist talk about T2 images, it just means like when water is bright and fat is bright if it's not suppressed. So on T2 images, when we're looking for endometriosis, we actually look for dark spots. So this dark area here and this dark area here, those are all endometriosis implants on the patient. And again, this one is where we're looking at T1. That's where we can see active bleeding or blood. And so here you can see, so it's really tiny punctate little foci. And those are the words we use in our reports that you guys love so much. And that's representing the blood that you saw on that prior image very similarly. But you can see that the resolution has significantly improved over the years, and it's making our evaluation, we're now down to sub-millimeter slices. So hopefully we don't skip over an implant as we're going through this and being able to evaluate it a little bit better. And, a lot of you guys do ultrasound, and you know that one of the tricks that when you're looking for it is you push the probe down and see if the bowel is moving with the uterus or not, and that's a sign of adhesions. So we can do that. We don't have to push on the patient. We just let them do their thing, and their bowel movement actually helps us evaluate this. So if we do a cine and evaluate bowel movement, we can see here that the rectum is actually adherent to the patient's posterior uterus here. And we're doing this in multiple planes. Here you can see that everything else is moving and it's stuck here on the bladder. And this is our newest protocol. We have recently rolled it out in the last couple months. We're now also giving glucagon to patients, which we haven't done before. It's a big nursing thing at UCSD to be able to deliver glucagon for an MRI for a patient for some reason. But so we do this part very early in the evaluation, then we give glucagon so we can stop the bowel motion. Because bowel motion causes a lot of artifacts for us, and then we can't see these little tiny things, right? So that's what we're working on. This is a different cause of pelvic pain when not you guys, but people have sort of varicosities in the pelvis, and we're trying to figure out if that maybe is a cause of pelvic pain, because we can treat that in interventional radiology. We can coil reflux in the ovarian veins. So here, this is when we're actually able to evaluate, because we're taking images every 10 to 15 seconds, and we can actually see the reflux of blood going down the left ovarian vein before it goes up it. And then we can diagnose based on an MR without sending a patient to the IR suite that a patient has reflux in her left gonadal and maybe a cause of pelvic pain and pelvic venous congestion. Although I know that's like a passé term, pelvic venous disorders. Okay, so, and then this is another one. I know pelvic floor is a big deal, and we have a lot of room for improvement on how we do that. But this is a patient just demonstrating a cystocele here, where you actually see her bladder falling down simply by bearing down in the MRI scanner while we're imaging. And then this again is the little cine where we actually make the patient, we put stuff into the rectum and then we make them defecate into the scanner. The olden days, we did fluoroscopy on these patients. And yes, there's a lot of value in doing fluoroscopy to evaluate for issues with defecography and whatnot, but it turns out that we can't see all of the muscles when we do that. So yes, the patient is in her natural position while she's in the fluoro machine and we can image it, but we can't see the muscles like we can with MR. So in MR, the patient is not in such a natural position when she's defecating, she's laying on her side, but if the problem's big enough, we're gonna see it. And for most of these patients that are willing to do this exam, they're so happy and to do this for us because if you can't go to the bathroom or have problems controlling whatever, you're not going to have a problem doing this. You want help. And I know that Mariana and I have been talking for a while, and we have our latest, I have a proposal going in now for, the next phase of protocols that we're working on, and pelvic pain with, avulsion injuries, and further developing our defecography studies as part of the next protocol development that we're working on. This is a project with Luis Laurent and Mana Prost, and Anna Rodriguez Soto is our amazing project scientist, who is the liaison and the person that makes stuff happen. So this is part of the HubMap project where Anna, grabbed the placenta after it was delivered and brought it to the MRI scanner, scanned it, and correlated it to the pathology afterwards. It's pretty cool. And it's hopefully going to help the study somehow in evaluating normal placentas. Okay, so let's move on to cancer. So this is where I spend a lot of my time is in looking at cancers. This is where most of the research that I do with your department is in gynecologic cancer imaging. And who's an engineer? Who are the engineers left? Okay, so this is for you. So diffusion imaging is really, really cool. And it's a technique this specific technique called restriction spectrum imaging, where was a technique that was developed at UCSD originally for brain imaging and looking at nerve tracts. But it turns out that you can use the same idea to look at cancer cells. The idea behind it is that cancer cells have large nuclear to cytoplasm ratios, and that water is what actually we're looking at for the most part in MRI, water is stuck inside of large nuclei. So you'll hear us, radiologists are like, is there restricted diffusion or is there not restricted diffusion, right? You hear us saying that. And then there's this thing called hindered diffusion. So there's free diffusion, which is like water moving, blood vessels flowing, that's free diffusion. Hindered diffusion is the water that's stuck in between tightly packed cells. So that's if you have edema from post-treatment stuff, whether or not You have infection that causes a lot of issues that look very similar. So that's hindered water. And then there's restricted water. And that's when we're looking really at the intracellular component. And we can separate that out with some cool math and modeling. And it turns out that for every organ, it's a little bit different. And so we have to understand sort of the model. So when people are like, well, why don't you just take the prostate one and apply it to the ovaries? It starts making me twitch. It turns out women and men are different. And our organs are different too. And how cancer presents in our organs and how to identify it is also different. So this is the model that we've developed for cervical cancer treatment and evaluation. So with cervical cancer right now, the main way to evaluate response to radiation treatment is that you have to wait 4 months to get a PET CT. 4 months is a really long time to wait to see if someone's responded to treatment because of the post-treatment edema. So with this technique, we're able to separate out edema from active live cells and really identify what's left of cancer, which is cool. So this is a patient before treatment, and this is a patient after treatment, and you can see it's prettier than the PET images. That being said, I actually really want us to have a PET MRI at UCSD, but we don't have one yet. I think that there's a really great application for gynecologic oncology imaging because these patients are, patients have to still get the PET and they have to get the MRI right now. It's really inconvenient. And it turns out that it would be really nice if we could do it at the same time because we get different information. If we're using this technique, this diffusion technique, we can get the information for the active cancer cells. We can also see the lymph nodes and do the staging. Since we don't have a PET MRI, I made some friends. I had a visiting scholar from Uppsala University in Sweden who came. She learned about the technique and then she brought it back to Sweden, and we've been able to collect some really great data, and I don't have to pay for it. So it's been cool. It's been a great collaboration, and I think really has driven the point home that PET MR is not just a really expensive technology. It's just one that we don't have because it's expensive. So hopefully we'll be able to get it in the near future. Here, this is ovarian imaging. So this is a project that Mike McHale and I have a CureBound award for, the Cure Prize. And this is looking at sort of we made a model now for ovarian cancer. We're a couple years into the study. And this is a demonstration of what cancer looks like. And it turns out that we can actually look at the vascular flow too without giving contrast as part of this modeling, which is interesting for us to be able to have a different technique to look at vascular flow and vascularity without having to give contrast, as well as the cellularity and the abnormal cells that are within cancer. This is breast cancer. And we're developing right now, one of the hot things out there is to try and develop a way to screen for breast cancer without giving gadolinium. So we now have this technology, which is we have less than 2 millimeter resolution to be able to detect cancer without giving IV contrast. In the future, we want to be able to predict tumor grade with imaging. We are collaborating with Dwayne Stupak in your department on doing tumor markers from those ovarian samples and looking at the genetics and looking at our vascularity and diffusion information and see if we can find some patterns that correlate to it. And I also think that we need to figure out different ways. I really want us to develop a technique to screen for ovarian cancer. And I know that's a spicy topic, but I do think it's a doable one. It's not 20 years ago. We have advances now. We should really try it again. And so that's sort of one of my current passion projects. This is the team we had. You guys will appreciate this. My team got me to get on a bike, and we were called the Ovary Achievers. And we collaborate with like half your department. And thanks to everyone for their funding and for listening.